Approach to carpal tunnel syndrome. So this will be a case scenario. This is a 55 years old female complaining of right hand numbness at night. So to understand what's the carpal tunnel syndrome, you have to understand the anatomy of the carpal tunnel. So the carpal tunnel, why it's called carpal tunnel? Because carpal bones form all three walls of that tunnel, and then a ligament is forming the roof. Inside the carpal tunnel, there is a group of tendons and the median nerve. There is other tendons and vessels and nerves outside the carpal tunnel syndrome, outside the carpal tunnel, so they will not be affected by the carpal tunnel. So what are the symptoms usually in carpal tunnel? Numbness, tingling in the radial 3.5 digits of the hand. That's where the median nerve supply the hand. Pain and paresthesia that awaken patient at night. Usually they wake up and try to shake their hands to minimize this numbness. Sometimes you can ask the patient to draw with the distribution of the numbness. They call it self-administrated hand diagram. The most specific test, 76% specific for carpal tunnel syndrome. And this is, the way they do it. So you give a patient a graph like this, and he will start drawing exactly where the numbness is. So basically, history is about numbness, distribution of the numbness, timing of the numbness, usually at night, waking up patient from sleeping, and then patient starts shaking. Physical examination. There is a lot of physical signs of carpal tunnel syndrome. Having muscle wasting or atrophy in the thinner muscles, that indicates a chronic carpal tunnel syndrome. There's something called Durkin test, carpal tunnel compression test. So you put your thumb on the carpal tunnel and compress for 30 seconds. After that, the patient will have pain and paresthesia, the distribution of the median nerve. So that means it's a positive test. This is the most sensitive test to diagnose carpal tunnel syndrome. Fallon test. Volar flexion of the wrist against gravity for 60 seconds. Usually this will produce the symptoms, less sensitive than the Durkin test. Tennell's test. So provocative tests performed by tapping the median nerve over the volar carpal tunnel. Once you tap on the carpal tunnel, patient will have some, numbness and electricity in the distribution of the median nerve. So that's also a good test to check for the median nerve. Innervation density test. So you get a paper clip. You just keep them maybe 2 millimeters apart, and then you start, touching the skin, see how far the clip, both ends of the clips are, and just see if the patient is feeling this or not. This is a good test to measure for functional nerve regeneration after nerve repair, and also after releasing the carpal tunnel. Other investigations, radiographs can be helpful if there is history of distal radius fracture, or if you worry about space-occupying lesion like a tumor or hematoma, etc. However, most of the time it's not needed. Other tests that can be done is EMG, electromyography, and nerve conduction study. Often this is only objective evidence of compressive neuropathy, valuable in work compensation patients. Some patients will come looking for work compensation benefits or time off, and they will give you a classic, presentation of a carpal tunnel. But there is no subjective way of confirming this except with the EMG and the nerve conduction study. So demyelination of the nerve sheath will give you, prolonged latency in the nerve conduction study. It means the conductivity is very slow. And the electromyography will show you that electrical activity of the individual muscle fibers is being less than normal. So that tells you that the nerve is affected. And that will confirm the diagnosis. So management. Usually start with a non-operative treatment, give patient non-steroidal anti-inflammatory medications, give them a night splint, advise them to change their activities to avoid any activities reproducing the numbness and pain. In some cases, injecting steroid in the carpal tunnel can give good relief of the patient. However, if all this fails, then carpal tunnel release is the best option after failed medical treatment. That happens by opening a small incision over the carpal tunnel and releasing just the ligament, just to give the nerve some space to breathe. And usually patients do well. However, there is, chance of recurrence, or sometimes if the patient had this for a long time and the release was very late, sometimes the damage will be permanent and the patient will not feel that much of improvement. Any questions? في أي أسئلة يا شباب؟
لا الله يحفظك، شكرا جزيلا. دكتور انت تشوف الشات معنا ولا لا؟
هي شوف هي.
يعطيك العافيه دكتور.
يعطيكم العافيه، شكرا لكم.